Well, it's my privilege to introduce the prostate session. Focused ultrasound has been used for prostate ablation for close to 30 years now. So I think we're at the point where we're past a lot of the science and more into the transactional aspects of treating with focused ultrasound. And I'm going to turn this over to Dr. Claire Tempany from Harvard University to take us into a prostate discussion. Thank you, Claire.
Thank you very much, Mark, and thank you all for sticking into the late afternoon. Probably one of the most important organs comes up next. So it's a pleasure to moderate this panel. I think we've got a couple of introductory slides, and then I'll go through the panel members and have them introduce themselves to you. Are the slides coming first, or should I do introductions first? Does anyone in the back know? Oh, I'm supposed to advance. That would make sense. All right, a couple of declarations of disclosures. So we're here today to talk about the role of focal therapy in prostate cancer. First of all, what is focal therapy? Really, focal therapy can be anything less than whole gland. So it's also been referred to as the male lumpectomy, just to sort of have the correlation with breast cancer. And actually that works quite well because there's also talk, of course, of combining an ablation therapy with radiation therapy or immunotherapy or other therapies similar to breast cancer. But let's get back to what is focal. So focal really is based on imaging right now, the definition sort of being either hemigland, focal peripheral zone, or focal lesion. There are multiple forms of ablative therapies that have been applied to the prostate, and they're listed there. And the numbers and then the asterisk there refers to a paper that just came out recently, which was an update on sort of the current state of affairs with focal therapy for prostate cancer. And this was a great paper written, senior author was Jürgen Federer. You can see that HIFU and MR-guided focused ultrasound is the most common ablative technique that's been reported in the literature, with 27 studies now documenting this in various stages of development. You can read the list yourselves. That goes all the way down to prostate artery embolization, which I can't imagine is really good for focal therapy. But there's the other ones listed for you. Reason that we're really excited, I think, in the last 10 years plus is that we've really now been able to define focal aggressive prostate cancer on MRI. MRI itself now can really show you very clearly, as is seen in these multiple images, focal clinically significant prostate cancer. And all those circles are shown T2 across the top and across the bottom, and the one in the middle is the diffusion-weighted image, which is probably the one that revolutionized prostate MRI the most, showing us the aggressive, and when I say the word aggressive or clinically significant, I mean something that contains a Gleason pattern 4. So we now can define the lesion, and there's a lot of data to show now that we really can do this well. And this is going before therapy, of course, back to the diagnostic stages, where we're now using MRI to determine who to biopsy and who not to biopsy. There are about 4 companies right now that are in this space that have received clearance, be it FDA or CE mark, across the world. And these companies are listed and shown to you in this slide, kindly provided by Mark and the foundation. And you can see that they sort of fall into 2 big groups first that we'll come back to. 2 are ultrasound-guided delivery of ultrasound therapy, and 2 are MR-guided delivery of MRI, of ultrasound therapy. And you can see the names of the companies, and we'll talk about some of these again in our panel. And so now I'm going to introduce the panel to you, and I'll have each of them say hello and give you one line about who they are and why they're on this panel here today. But we should probably do this a little bit, and well, are we sitting in the right order? Not quite. But so I'll start from my left. I will start with Hugo. It's a pleasure to introduce Hugo Embert, who's the VP for Marketing and Reimbursement at Focal One. You want to say hello?
I want to say hello, and thank you for having us.
Thank you very much for being here. And next up is Pejji Ganuni from Stanford University, who's an associate professor of radiology there. And Pejji, you want to say hi?
Hi, everybody. Thanks for staying till the end.
Thank you. Next up, we have Karen. And so it's a pleasure to introduce Karen Cornett. She's the VP for Clinical Operations at Sonoblate.
Hi. Thank you for having me.
And last but not least is Bafar Adai, who's a urologic surgeon at Memorial Sloan Kettering in New York.
It's a pleasure to be here.
And not last but not least, I'm forgetting my Zoom colleague here, Rajiv. So it's also a pleasure to introduce Rajiv Chopra, who's on your screen somewhere. Are you seeing him? I know I can see him, but can the audience see him? There he is. Okay, good. Now we have you up on the big screen. So Rajiv is UT Southwestern and Associate Professor of Radiology, very involved in the early days of the Profound device.
Nice to meet everyone. Thanks.
You're here, good. All right, so let us start our panel discussion. The discussion, I have been given a list of questions by the foundation that are sort of questions that we can use as ways to talk, okay? We don't have to focus just on the questions because I think we want to really get a conversation going here about the differences perhaps and the clinical impact of this therapy and how it's going to translate into clinical practice. So my first one is for Hugo. Hugo, the adoption of focal therapy or HIFU for prostate cancer has really, I think initially and very much today, is still patient-driven, as in the man is coming in and saying, I've been diagnosed with prostate cancer, I'm very worried about whole gland therapy, I'm looking for something a little bit less than whole gland. When is it going to pivot, do you think, to become much more physician-driven, or what are you seeing from your perspective?
Well, that's a $1 million question. I mean, to my point of view, I mean, the earlier the better, of course. This
I know.
industry point of view, we've been trying to help drive this adoption, of course, trying to promote this and to spread the word amongst the scientific and clinical community. It's not necessarily easy. It's a difficult paradigm shift. Prostate cancer has been seen as a multifocal disease, which it is in a lot of cases, but still, with now the acceptance of active surveillance for those low-risk prostate cancer, and it's been proven, it's supported by level 1 evidence, and it's part of all the guidelines, active surveillance is. And on the other end, the progress in imaging, and especially MRI, which also has been proven to play a significant role in the diagnosis. I think the path is really clear for focal therapy, and hopefully will start to make its way in the guidelines. It may need to have some level 1 evidence. There are several level 1. There are several RCTs that are in progress. That can be debatable, whether they're appropriate or not, comparing, randomizing to active surveillance, focal therapy to active surveillance, or randomizing focal therapy to robotic prostatectomy, for example. Is that the right comparison? That's the comparison that's been made right now, so we'll wait for the results of the RCTs, which hopefully will help this become a standard of care.
And from your perspective, though, with Focal One and marketing it and reimbursing it, what's the story that you're telling the physicians, or how are you marketing this, I mean, so far as that goes?
Reimbursement, of course, in this country, if we focus on the US, where the story started after Europe, but goes faster. Reimbursement is a huge driver. Of course. So
always.
The ability of getting a CPT Category 1 code for the transrectal application of HIFU, plus then having Medicare, CMS set the appropriate payment rate has helped driving. But we still need coverage from all insurance companies, and they a lot rely on guidelines and things of that nature, which makes it longer than what we hope.
So you're seeing a lot of out-of-pocket?
Still, but not as much. And we saw a big evolution since 2021. Sorry, in January 1st, 2021. That's when the CPT Cat 1 code became effective, and that's where we really saw a shift between a cash pay procedure that HIFU was perceived at into a more mainstream with coverage type of procedure, when Medicare started to pay for it pretty much across the board, and insurance company getting more and more on board as well.
Yeah, does anyone else on the panel want to jump in on reimbursement? I think it's a big issue, and I don't want to change subjects and questions, but maybe somebody wants to think or share some of their experience with that.
Reimbursement has been an issue. Hugo and I have actually worked closely together on reimbursement. I do think that we're headed in the right direction. I think that has been a limiting factor, but it does feel like we are on the cusp of focal therapy becoming mainstream. I think the guidelines typically are always a little bit late, but I think we will see them soon catch up as well.
All of our patients have been covered by Medicare, which covers these ultrasound-based ablation methods. I think prior to the change in the code that Hugo mentioned, my colleague in urology that does Sonoblate did have some patients that were paying cash if they weren't covered under Medicare, but that's largely been eliminated now.
Great.
We have patients that ask about cash pay, but we haven't pursued that. I know there are places that do solely cash pay for some of these approaches as well.
Yeah. Great. Well, thank you very much. Jumping down to Bafar, can you talk to us a little bit about, from your urology colleagues, sort of the interest level in using focal therapy and in having that in your practice and the training of young urologists in this space?
Thank you, Dr. Tempany. I think it's important to put context into some of this discussion about adoption. So as we know, as a group, 250,000 men a year are diagnosed with prostate cancer. It's still the leading cause of male single organ cancer in the United States. And with the continued adoption of prostate cancer screening, which has now been reinforced and reinitiated after a few years of what I consider the dark ages, now we know that 50% of men being diagnosed through screening have low risk or low volume prostate cancer. So the volume of men now that we see that would be candidates for partial gland ablation or focal therapy is high and continuing to increase. What's important is the concept of focal therapy isn't new. There was consensus statements and papers written back in the mid-2000s discussing the role of focal therapy within the urology community. The reason it was never adopted was for the classic barriers that have always obstructed minimally invasive procedures, which were, one, in prostate cancer, it's a multifocal disease. Two, that the concept of imaging is critical in the way urologists diagnose prostate cancer up to about 5-10 years ago was a systematic biopsy based on ultrasound regions being biopsied. And so what we've adopted over the past 5 years in urology across the spectrum of academic and private practice is better techniques to detect prostate cancer with image-guided biopsying, mapping prostates, but most importantly, as a community, we now know that 75% of men with low-risk prostate cancer are being enrolled in active surveillance. That's astonishing. In the beginning of my career, when I started, we were doing research on ways to better communicate risk to patients to adopt active surveillance. We've passed that threshold. So now we've anchored our patients to the concept that prostate cancer in many forms is not lethal, and your quality of life is more important. And they've adopted this. And now we can't take a step back with this large population of patients who've now been surveyed, monitored closely, and in the way they fail active surveillance is not through metastatic disease or high-grade disease failure. It's increase in volume of disease, slightly, or grade of cancer, or image-detected cancer. And so to tell these patients now that we were surveying you because of your low-risk prostate cancer and it provides no risk or harm to your long-term longevity, but now you've fallen off a cliff and we have to remove your entire organ or do whole gland radiation, in my view, is unacceptable. And I think the urology community, especially younger urologists who are leading the field in being proponents of active surveillance for low-risk disease, and that's also including some favorable intermediate-risk disease, will be the ones leading the charge, focusing on a patient's quality of life. So what the role focal therapy has isn't to convince the community of urologists and radiation oncologists that we should reduce the burden of our treatments on our patients, improve their quality of life. Their only burden that focal therapy has is to demonstrate that there's a clinical benefit to patient without a significant harm. And that's where our trials are going. My belief in the trials that we've been fortunate enough to run and now have approved by the FDA are primarily with the concept, let's keep men on surveillance without the need for radical treatment or radiation therapy as long as possible. And by doing that, we can improve quality of life, continue to show that prostate cancer screening's harms are reduced significantly because we're not taking patients to the operating room on every new diagnosis. And it's safe because we're extending patients' quality of life without jeopardizing their long-term outcomes. And so we can demonstrate that very simply by having registries with long-term outcomes showing good results with regards to metastatic disease and survival. This can be done on retrospective studies and longitudinal series, but specifically in randomized controlled trials, demonstrating that we can safely monitor these men and extend them from the point of diagnosis to needing radical treatment.
Yeah, it's really good points. And Pejji, you may want to jump in on this too, because this was a question a little bit later on for you, but how you use both transurethral and transrectal therapies. Tell us a little bit about your experience on avoiding the side effects and how you preserve the bundles, the urethra, the sphincter, and how you think about that during a therapy, because that's exactly what Bafar is saying. We have to reduce the side effects.
To add a little bit more information on what Bafar was having to say, that although this funnel is very wide in terms of the number of men that end up in surveillance, as he alluded to as well, by between 5 to 10 years, as you know, 40 to 50% of them have moved on out of surveillance and need some kind of therapy. So it's a lot of men going into surveillance, but then ultimately a lot of men needing some kind of therapy. And I like the way that Bafar said it, that taking them from surveillance all the way to whole gland radiation or prostatectomy is a big jump.
Yeah.
And thankfully now we have this kind of intermediate tool. The technology basically sells itself when we talk about the side effects for patients. At least at this point, when we're talking about patients that are seeking this technology, they've done their homework, many of them.
Right.
Some of them have been fortunate to talk to urologists like Bafar, who are open-minded as well, and have gone over the limitations of prostatectomy and radiation. There's a subset that you kind of interact with that say, yes, it's true, prostatectomy has a high rate of ED or incontinence, but my patients don't have that. So you have to kind of,
Yes,
I don't know who there's one urologist out there that must have really miserable side effects, because everybody you talk to, their patients don't have it. It must be somebody else that's driving the averages up. But the reality is that those treatments cause a lot of problems for patients, and we can offer them this alternative that has been proven repeatedly to be safer than these alternatives. We've shown that in multiple studies now. I think the onus is on efficacy, and right now it's good, maybe even very good. You know, everything seems to be hovering around 80% over 1 or 2 or 5 years or so follow-ups. But I think bringing that number up as well will only help in terms of adoption and increasing the demands. But as far when it comes down to talking to them about lower levels of ED, avoiding incontinence, you're preaching to the converted.
Yeah, no, absolutely. And I think the patients themselves are still driving this by doing the research and figuring out that they don't want to take that unacceptable leap, to quote Bafar, from active to whole gland. And it's absolutely a major bridge between those two therapies. I think that's very well said. Changing subjects just a little bit, Rajiv, to bring you into the conversation, please. There's been about 15-year data now at this point. How are we going to get all of these guidelines changed to allow it to be accepted rather than be just, quote, still in a clinical trial, or clinical trials are pending, or however some of the guidelines are written?
Well, I'll give you my contribution to that question. Others will have opinions too. I think it's tied to utilization guidelines. The technologies need to be used more. I personally think, from your table you showed in the first slide, there's ample studies at this point. I mean, you had 27, I think, HIFU studies. I mean, I'm
Yep.
not sure how many more we need, to be very honest. The challenge I see, which maybe feeds into guidelines and utilization, is, and I'm currently spending a lot of time outside the academic world, more in the private world, trying to increase utilization of these technologies, is especially in the world of urology, a lot of technologies, proton therapy, radiation therapy, surgery, are tied into business models. They're intimately, you cannot extract them from the business models with urology groups. And if HIFU as a technology doesn't have the same approach, it just won't be competitive. So I think that's an area that needs to be, addressed and served, and I think it will yield utilization.
Yeah, well said. Does anybody else want to jump in on the guidelines or the change of practice? Hugo?
Yeah, I mean, guidelines is one of my favorite topics.
Good.
I really don't know how it works. And often when you read the guidelines, you say that's an expert opinion. But that word experimental that has been written in every guidelines, every significant guidelines, whether it's the EAU, the AUA, and all the guidelines around the world, I think they underestimate, the people who write this word underestimate the impact that this word has in the making a technology available to the patients. And back to your question, how much data does it need? What we've heard one day with the FDA said, hey, literally you would need 15-year data on a randomized clinical trial with thousands of patients to prove superiority or at least non-inferiority with surgery for those low to intermediate risk prostate cancer patients. And we understand you can do that. So what do? I don't know, you figure out. Bye-bye.
Yeah.
So I don't have the answer. As I said earlier, I'm hopeful that those 2-3 randomized clinical trials that are in progress right now will help check this box with regards to the guidelines moving towards a more favorable statement. Having said that, I have to applaud the AUA because this year, for the first time, they changed a little bit their statement. They updated their guidelines for localized prostate cancer, and they had a far more favorable statement for ablation for those intermediate risk prostate cancer patients. I don't exactly remember the exact words they used, but the word experimental was not part of it.
Good.
Which was good, and hopefully that's going to continue in this direction.
Thanks. Bafar, did you want to chime in on guidelines at all?
Yeah, so I'm an optimist. So what I would suggest is I hear clearly Rajiv's point about misaligned incentives in medicine and why the financial model is important in everything we do. And I hear what Hugo's discussing about the burden of evidence and guidelines. And as I sit up here, I actually thought of a study that we should probably do, which is look at the history of active surveillance and its adoption into our guidelines. It's actually fascinating because active surveillance, the moment of adoption, eliminated 30% of radical prostatectomies and radiation treatments in urology groups and in academic centers. So it goes against the concept that it had to be financially viable to be adopted. And if you look at the literature supporting active surveillance, initially it was primarily based on retrospective data, long-term, 10, 15 years, but led by, for what it's worth, centers of excellence that united and said this is right for our patients with the banner that was waved of quality of life. And so I think that model provides us an opportunity to study and learn why did that enter our guidelines and adopt in our practices, and yet we've been resistant to focal therapy, which we can argue from both the financial perspective and a data perspective is far along than active surveillance.
Yeah,
It's a
well
very
said.
hopeful perspective, and I admire it, actually. And it's a good point, honestly, that AS really hit the pocketbooks of urologists, right? And there's fewer prostatectomies. I'll draw on a couple of examples from other applications, right? So when ET was approved and an RCT came out, there's always something else to quibble about, right? Well, you did your RCT versus sham.
Right.
Not versus DBS. It's not valid. You know, oh, your data's only 1 year. I want 2 years. I want 3 years. I want 5 years.
Yeah.
There's always something else. You know, if you look at fibroids and you look at, we were looking at this the other day after the fibroid session, the policy statements from insurance companies, if you can't tell the difference between their confidence in the data behind FUS for fibroids versus, let's say, RFA for fibroids. But at the top of the page, FUS for fibroids is considered investigational. RFA for fibroids is considered medically necessary. What's the reason for that? Well, on the ones, the gynecologists control that. The societies are behind that. How did ET eventually get, you know, through that obstacle course? The societies got behind it. The neurosurgeons supported it. Neuroradiologists and so forth supported it. So there is a practical aspect that I think supports what Rajiv is saying, and then I think that there's also a hopeful aspect that is supporting what Bafar is saying as well. But I do think that, you know, the fact that you guys got a code, for example, that came through the society support and the AUA coming around with you guys and backing you to do that. Somehow we need to make those efforts more broadly. I don't know whether another RCT will do it. It might help move the dial, but I feel like it just leads to more arguing and why did you do it that way? Why did you, your endpoint is not my endpoint, et cetera.
I agree with you, and I love the positive thinking of Bafar. Having said that, for active surveillance, it's an RCT, it's the pivot study, that really gave an excuse for the guidelines to evolve and say, okay, yeah, it's backed up by an RCT. And if you read the pivot study, you probably know this far better than I do, the pivot study is not really a successful trial. It failed to enroll, to accrue. The follow-up was not exactly what was initially planned, but still, at the end, they came up with a survival curve that showed that 10, 15 years, there doesn't seem to be much difference between patient that nothing versus patient that had a radical prostatectomy for the Gleason 6, and that's back to my check the box concept. All of a sudden, the box of an RCT could be checked, and I agree with you. All the data was there prior to that was sufficient, far sufficient to support active surveillance. But at least that check the box is, and that's what I hope we're gonna go through, we're gonna leave through with HIFU and focal therapy. We have all this long-term data now for ablation in terms of safety and efficacy. I think we're confident. Everyone is confident. We just need that RCT to check the box, say, okay, now we can make it to the guidelines. That's my hope.
Yeah, I want to pivot a little bit, but before I do, I want to just remind the panelists and anybody who's virtual, if you have any questions, please submit them with your Q&A button. Karen, BPH, so benign prostatic hyperplasia, is a sort of secondary item for manufacturers, as there are many low-cost alternatives for this. But apparently, reporting from Neil and the foundation, a lot of patients are inquiring, can these focal ablative techniques be used for BPH? How are you guys handling that, or what are you thinking if you say, don't think about cost for a second? I know it's almost impossible, but try not to think about cost. Would these be applicable?
I think so, actually. You know, our company, the way that we started was actually with BPH. We were treating benign tissue, saw that it was effective, and then transitioned over into cancerous tissue. So I certainly do think that it has a place. I think what you have seen as far as why it hasn't been studied more is because of the money issue. I know that we're not supposed to be talking about that, but that really does have a lot to do with it.
Sure.
You do have patients who fail standard BPH treatment, so they are looking for something else. I think you're actually going to start seeing some more clinical trials with HIFU and BPH. From a manufacturing standpoint, it does make sense. I think from a commercialization standpoint, it makes sense that you have one device that can now treat two different catchments, right? In this country, again, I know I'm not supposed to, but to bring money back into it, I'm sorry. I'm not sure that it makes complete sense, but for other countries, I think it could make a lot of sense.
Yeah, yeah, good. Thank you for that. Anybody else want to address BPH at all? I think it's obvious that if you have one device and you can do two things, and certainly some of the approvals have come out for just prostate diseases in general, of course, not just for cancer, so clearly it can ablate them. Issues, of course, come up with, certainly with the reflection of calcifications and some of the pathology that BPH, of course, is well known to contain corpora amylacia, various areas of reflection, but that might reduce the efficacy somewhat. And just generally then, one of the couple, getting towards the end of the questions that I've been given to ask you, there's a couple of different approaches now that we're all aware of course, and many of us are using, both transrectal, transurethral, and then there's a transperineal option potentially as well. What do you see as being sort of the appropriate role for each of these? And Peggy, I can come to you first, perhaps, because we talked about this in the back of the room, trying to determine when you have a given patient, should I be doing this transurethral? Should I be doing this transrectally? And I know we don't have experience that much with transperineal, but do you want to give us some thoughts on how you're doing that?
For us, we have a transrectal ultrasound-guided system in the hands of my collaborator in urology, Dr. San, without whom we wouldn't be anywhere as a program, frankly. We also have the transurethral and transrectal MR-guided systems, and it's basically a combination of gland size, which can impede transrectal approaches as well as transurethral approaches, as well as the calcification distribution and, of course, the location of the cancer. So that kind of matrix put it together, and you can kind of figure out which of these different options makes the most sense for patients. So, for us, if it's an anterior lesion, especially in a larger gland, we're going to probably use a transurethral approach as long as there isn't calx in the way. If it's a posterior lesion in a smaller gland, you could do a transrectal, either ultrasound or MR-guided approach. If it's a bigger gland, then we'll probably use a transrectal approach with MR guidance.
Yeah, I think that's wonderful when you can have a choice to do it that way, because we all know prostates come in many different shapes and sizes, and to be able to do it that way. Does anyone else want to address that question or comment? Please.
I'll make a quick comment on 2 points. I think centers that have invested for their patients the ability to do focal therapy up front have made the decision that multimodal treatments are required. Whether it's our traditional treatments that we've had in the past with cryoablation, or more novel treatments with our MR-guided high-intensity frequency ultrasound treatments, or electroporation, or ultrasound-guided procedures. So that begs the question, I mean, maybe for Rajiv to answer, but why can't consolidation in this space, like it has in every other space, occur? You would think that a single company that under one banner that can provide all of these services and may have a leverage instead of each company working, in essence, against one another for a smaller and smaller slice of patients. So that's a thought that I have. To the larger question of reimbursement, if I can go back for 2 seconds, I think we see where we're going, and it's towards bundled payments. I think healthcare systems that can sell services to payers that will take the life cycle of that patient from the moment of diagnosis to the moment of death for each patient with an upfront agreed upon payment, and then can deliver that payment, will be the winners. That's the future. So from that perspective, focal therapy should be incredibly inviting to both the institution, because the outcomes are known, and for payers, because it will fall within that realm of lowering costs that we know have really spiraled out of control. And I don't know if I have my radiation therapy colleagues here, so it's probably unfair for me to state this, but really pushed by the radiotherapy innovations and technologies. So those are 2 points, is saying, yes, payment's important. This is the direction I think we're going, but also from a focal therapy perspective and different treatment options, as Peggy very nicely outlined, why can't we have consolidation?
Yeah, and many of these therapies can be done in smaller and smaller clinic spaces, not to be in the major tertiary or quaternary care centers. So the bigger hospitals, you can see obviously the portability of the devices, the ease of access. So that's certainly, if you think of it in terms of the life cycle, it makes a lot of sense too. You'll reach more of your patient population out in the community with these, if you're able to establish centers to do it there. That makes a lot of sense. Anyone else want to jump in on that? Comments? We can check if there's any questions here. There was one other question that came through on an email that I remember, was also if we could speak to the adjunctive therapies that could be combined with MR-guided focused ultrasound or ultrasound-guided ablation. We've talked, I know back in the day with Mark Hurwitz and others, of combining, like I mentioned at the beginning, the lumpectomy ablation with radiation, low-dose radiation to the remaining prostate, because as we know in radiology, what we're trying to follow these patients, because as Hugo said at the very beginning, this is a multifocal disease. So you treat the dominant index lesion with an ablation. You know that you have to surveil that gland for the rest of that patient's life, essentially, with PSAs and biopsies and imaging and all kinds of things. And we're trying to come up with some algorithms on how to determine and detect and with MRI to define local recurrence or recurrence within the gland. But maybe it's better to upfront have something like a low-dose radiation that would control the rest of the prostate. And I throw that out to anyone who's thought about it, or other combination therapies. Are there chemotherapies, immunotherapies? Are there other things that we could be doing in combination?
So some of this is actually starting to be studied in the UK. So Imperial College has a trial that they're currently running for patients with metastatic disease, where they are trying to treat that index lesion and also follow that up if the patient does need some radiation and that sort of stuff. That's the Atlanta trial. There's also a Kronos trial, which is going to be multi-arm, where they do focal therapy with other adjunctive therapies as well. So I think that's very interesting. I think it needs to be studied some more, and we need to see some more data.
Yeah, yeah. Any thoughts?
Yeah, I think first we have to define where are we failing with focal therapy. And my experience in reading the literature is not systemically. So the goals of focal therapy for local treatment, we may be able to improve outcomes by doing things that I've spoken to Peggy a lot about, but expanding our treatment area, improving our imaging, receiving real-time feedback during the treatment to improve our treatment at the time of the initial treatment. But when you start adding systemic treatments, especially, for example, I think it changes the risk group of patients, which actually has benefit. I mean, Stampede, which demonstrated that radiation treatment in the setting of metastatic disease, radiation to the primary improves overall survival, was a clear indication that we should do something in the primary setting for patients with metastatic disease. The reason as urologists we haven't jumped into this space 20 years ago was because a patient with metastatic disease will ultimately fail systemically, and providing side effects of that treatment locally seems very little benefit. However, focal therapy could be the surgical armamentarium that is required in these settings with metastatic disease, and we're closer to the goal line, which I consider the benefit with regards to metastatic disease moving to overall survival, of demonstrating a clinical benefit in that setting where your duration of treatments or studies are much shorter if you're dealing with patients with, unfortunately, with metastatic disease. So I think there will be a role for focal therapy combined with systemic treatment in patients with metastatic disease, at least being studied. And I leave it up to my colleagues in work that's being done in the immunological space as well.
Yeah, and I think we're working hard on the imaging space to really try to understand recurrence or residual disease. It's hard in the treated gland. I know this is one of the places where we definitely need to use intravenous gadolinium, for example, which most people seem to want to throw away for prostate completely, which is somewhat inappropriate. But I think we still have to learn a lot about looking for recurrence. And maybe this is where I've not had a lot of experience with PSMA or PET agents, but this is a place where I think PET will probably help us target where is the local recurrence, and we certainly know it's working in oligometastatic disease at initial presentation. But any experience with that yet, Peggy, and looking at other modalities rather than MRI?
First of all, I completely agree with you that I don't treat anybody with focally without having a post-con scan. The extent of the disease, I think, is better delineated there, and I think you're much less likely to have some residual if you take that into account. I think, by the way, that kind of variability, as well as variability in the methods and density of biopsy, you know, if your screening methods vary, then it's a little bit of garbage in, garbage out, right? You're going to get heterogeneity in your results. So, you know, in terms of these trial designs and so forth, the more standardized that gets, the better in terms of arriving at an ultimate efficacy. But to your question about the use of PSMA and so forth, we have used it in part for screening purposes if we're concerned that the patient may have other risk factors like PSA, et cetera, that might suggest that they may already have or at risk for extraprostatic disease. We will look on PSMA. Obviously, there's limitations in terms of sensitivity there.
Yep.
We've also done a case where after 10 years post-radiation, somebody had local recurrence in the prostate as well as a node that was positive. They couldn't re-irradiate the prostate, so we ablated the prostate recurrence based on the PSMA distribution.
Yep.
The MRI, as you said, was almost uninterpretable 10 years post-radiation, but the PSMA helped us with localization, and then they were able to irradiate the node. That person's done quite well. So there are roles for salvage and using some of these other techniques.
Yeah, exactly. And obviously cryotherapy has been used for a long time as salvage modality, and I think it's well established there. Rajiv, did you have any thoughts about any of the recent topics or anything you'd like to address?
I mean, I'll just reinforce what Paige is saying about PSMA. I'm also very excited to see the role it's going to have, even in this context of not metastatic disease, but, you know, planning and ensuring recurrence or salvage therapy. So, yeah, very excited about the future that holds for focal therapy.
Great. Any questions from the audience? I forgot about you guys. I'm looking at the iPad all the time. Any questions? Awesome. Well, I would love to thank all our panelists. It's been a really good conversation. I think we've hit on the really important issues. It's very exciting that we have 3 approved devices in the marketplace. I think the awareness across the country and the world is really, really picking up. I think our urology colleagues are definitely embracing it, and thank you, Bafar, for leading the way on that. And Peggy and I will follow up with our imaging and try to make it better and better all the time. And thank you both from industry and advising us on reimbursement issues and all of the guideline questions. I think those were really very well addressed. So a round of applause for the panel. Thank you very much. Thank you all. We're finishing a little ahead of time, so this gives the next session, I think, registry a lot more time to talk than they thought about.
Hi, folks. We're going to have a short break. I'd ask you to be back here about 4:25. There are snacks set out in both the hallway and the other room. But please come back for the registry panel and then the gene and cell therapies panel. Again, 4:25. Thank you.